uninsured people. There's also a shortage of primary care doctors, particularly in parts of Baltimore City where many people don't have access to a car and can't easily get to doctors elsewhere. So how do we make our world-class healthcare accessible to everyone? What innovations have we tried? What haven't we tried that we should? We've brought together some of the healthcare industry's preeminent leaders to tell us. Before I introduce our panelists, please note that there will be a few minutes at the end for questions from the audience. If you want to share panelists' insights on social media, please use the hashtag #ImpactMaryland. And finally, we want you to think of this conversation as an entry point to the big ideas that can solve some of our community's greatest problems and make a positive impact. Now let's meet our panel. Joe Ochipinti, CEO of United Healthcare Mid-Atlantic Region. Bradley Chambers, Senior Vice President and Chief Operating Officer of MedStar Health, Baltimore Region. Dr. E. Albert Reece, Dean Emeritus and Endowed Professor and Center Director at the University of Maryland School of Medicine. Kevin Sowers, President of the Johns Hopkins Health System and Executive Vice President of Johns Hopkins Medicine. Katie Wunderlich, former Executive Director of the Health Services Cost Review Commission. And our moderator for this panel will be Neil Meltzer, President and CEO of LifeBridge Health. Take it away, Neil.
Thank you. Well, I think we're going to jump right into it. I'm going to start with an easy one. And this is for the entire panel. In one word or a sentence, name the one thing that makes you proud of Maryland's healthcare industry and the one thing that keeps you up at night. Why don't we start with you, Joe?
Yeah, sure. Thanks, Neil. I would just say being up on stage with this collaborative group of leaders with one common goal, right, to provide the best world-class service for Maryland.
Terrific. And what keeps you awake at night?
Other than my 15-year-old child, now that he's moved on from putting deodorant on and doing a bunch of cologne and other things. But honestly, when you look at our great state, you look at the diversity and the population, there is so many differences in regards to the level of care as it relates to the inequalities. And that keeps me up at night. How do we serve all populations at that individual level?
Excellent. Thank you. Brad?
Joe, summarized it well in terms of what we're proud of, but the word that comes to mind for me is resilient and resiliency. Our industry went through so much during the pandemic, and even moving forward, Joe mentioned many of the disparities and inequities we have in healthcare, but we keep plugging away. We know at the end of the day, it's about the patient, and it's about the patient needs, and that's really what has inspired me and kept me going. But on the flip side, what I'm worried about moving forward at night is the workforce for tomorrow. Mm-hmm. Where are the future nurses, radiology techs, pharmacists, physicians out there? And I know we might get into some of that today, but we really have to develop that pipeline of future healthcare workers in this state.
So true, thanks. Good segue to Dr. Reece.
So that which I'm most proud of in the word is innovation. We as a state, with both the health system and the institution, the medical organizations, are clearly one of the leaders in the country and provide the innovations that actually drive medicine across America. So I'm proud of that. That which, I sleep well at nights, by the way, but that which, if something really had to keep me up at night, it would be the concern that the high quality and the innovations that we have is not entirely accessible to all. So that's what would concern me.
Okay, thank you. Kevin?
So I would say that collaboration comes to mind because it's a lesson that I think we all learned during the COVID pandemic was that we are stronger together than the competitive environment we were working in prior to the pandemic. And so I think if you look at how we collaborated as entities with the city, with the state, to respond to the pandemic, that made us stronger in Maryland's response. I would go with workforce, and the only reason I say that, and I'll take a different angle, because Brad and I have talked about this often. I'm worried about workforce because of the access issues it's creating. So, for instance, the symptom of workforce shortages, people are talking about ER waits, but ER waits are a symptom of a much bigger issue. On any given day at Johns Hopkins Hospital, we have 20 to 25 people who are waiting a bed in a nursing home. That's one hospital. So if you multiply that across the state, and we've seen a 40% decline in beds in skilled nursing facilities in the state. If you also then think of the behavioral health issue, when I was rounding in Howard County the other day, we have an 11-bed psych unit in our ER, but we also had 7 patients that were behavioral health patients blocking ER beds. If I look at the issues of custody cases and wards of the state that don't require medical care, but they have no other place to put them but our hospitals, it's a combination of workforce challenges that are creating variables that lead to a symptom of ER wait times, which creates access issues. But the symptom is a bigger issue for us to solve collectively as a healthcare system. And I mean just not a healthcare system and hospital related, but beyond that, post-acute care and everything else.
Terrific, thanks. So you don't sleep at all?
Ben, tell me how you sleep.
Katie?
Thank you, Neil. And I'll build on something that Kevin said. One of the things that I'm most proud of our healthcare delivery system is the stability and predictability that we have through our rate setting system and the Maryland model. And that was most evident during the COVID-19 pandemic. The system that we had in place allowed hospitals to focus on what they needed to do, which was to focus on patient care, to focus on changing the footprints of their hospitals to make sure that they could handle what was coming in through COVID-19. And the Maryland model and the rate setting system was able to take one of those uncertainties off the table, which is the financial uncertainty. So that was something that I was incredibly proud of through the pandemic. But that also highlights something that keeps me awake at night, which is the health disparities that we saw illustrated and highlighted through the COVID-19 pandemic, access to care in the community to help maintain or improve chronic conditions. That's one thing that we're still really trying to drive towards and solve here in Maryland.
Well, while you have the mic, Katie, we hear a lot about the burden of uncompensated care and what it puts on hospitals. Can you explain in layman's terms how our unique rate-setting commission works? I think there are a lot of people in the audience who don't fully understand the unique nature of the state of Maryland.
Sure, absolutely. I'd be happy to. And this is one of the things when I speak to folks around the state, to other industry leaders, one of the things that I'm really proud of Maryland is our rate-setting structure that provides a number of benefits. But specifically for patients, we have a system in Maryland where every person, regardless of their ability to pay, regardless of their insurance status, is able to access care, hospital care, at any hospital across the state, at the world-class academic medical centers, at the esteemed community hospitals. Patients are able to access care where they live and where that is convenient for them. This means that we don't have any public hospitals in Maryland, and that's a tremendous benefit to Marylanders. There is not a two-tiered level of system as there are in other states where patients that have commercial insurance are able to go to one hospital, but patients that have public insurance or are underinsured or uninsured are relegated to a different hospital. Patients, regardless of their ability to pay, are able to access those services. Now, for our hospitals that are situated in areas that are underserved and vulnerable populations and that serve those populations, they're able to tap into a statewide financing pool through this unique all-payer rate-setting system, which means that the financial responsibility of caring for and providing care for individuals that have an inability to pay is shared equitably, equally across the state, across all of the hospitals. And so we really create a shared healthcare good across the state by providing a financial pool that allows hospitals to serve patients that cannot pay.
Well, thank you, Katie. In spite of that, we still hear about disparities in care, And I'm interested in, Brad, in what you're seeing in terms of disparities and how they're being addressed.
Yeah, I think everyone has heard throughout just our brief time here referring to the inequities and disparities of care. They always existed, but I like to say during the pandemic they became amplified because you really started to see the gaps in coverage. But more importantly, we also saw the direct correlation between the social determinants of health along with access to care. And in particular, two areas in housing and access to food. I'll just comment on one, access to food. Throughout the state, and unfortunately, particularly here in Baltimore City, we have various communities where there are no fresh produce, there are no grocery stores. Citizens do not have access to proper food access. And so one of the areas where hospitals have had to step in, as Katie said, we do not have a public health system, but the hospitals take on this responsibility, was the creation of what's called a food pharmacy. So within the MedStar health system, we have 2 hospitals in Baltimore City that have these food pharmacies, and we're going to open another one in Baltimore County and another one in Prince George's County. But picture where a patient can come on site to a hospital, a physician, usually a primary care physician, can write a prescription where they actually identify that there are food insecurities for this patient that are impacting their overall health and welfare. That patient can come on site to the hospital, there's a food pantry, and they can receive up to so many weeks of food for them and their family based upon the size of the family. And we partner with institutions like United Healthcare, the Maryland Food Bank, other vendors collaboratively, the American Heart Association, to set up these collaboratives within our hospitals. Now, on the backside, we see the benefit because we're now seeing patients who are utilizing services less. The ER is not the appropriate use of a service. And we're seeing, especially in diabetic patients, we're actually seeing their levels come in line more where they should be, and they're not coming in for unnecessary hospitalizations. That's just one example. I think Kevin and I together can talk of multiple collaboratives that the hospitals are doing, particularly in Baltimore City. But we quickly realized coming out of the pandemic, our responsibility doesn't end when that patient leaves our 4 walls. Kevin spoke to some of the challenges that we see in moving patients through. There's an entire continuum of care. And through the disparities that we've seen in our targeted communities, hospitals now are partnering more with nonprofit organizations to step in targeted communities and really offer the services that are needed at a baseline. And that really helps us out moving forward because we're taking that care back into the community.
No, thank you, Brad. LifeBridge itself has about 45 different programs in Baltimore City alone. And I know, Kevin, you're doing an awful lot to reach out to the community as well. Can you share a little bit about what Hopkins is doing?
Hopkins has multiple programs, and I'll tell you there were some great lessons learned from the pandemic and partnering with the University of Maryland. We went into housing units for the elderly who could never have come to a center to receive their vaccinations. And so clearly we reached out in a meaningful way. And now we're thinking about how do we take that lesson learned and even go further of how better to serve vulnerable populations. I would say as you look over in the zip codes of Bayview, thank goodness for Father Joe at the Catholic Church, because Father Joe was able to help us educate and get people to vaccination sites. And so the relationships that Brad are talking about in terms of in the community and making those connections go far beyond what we as a healthcare system can do by ourselves. We have programs around diabetes. We're developing the food pharmacy that was talked about. And so clearly the outreach to our communities, but partnering in our communities is even the more powerful way to serve vulnerable populations.
Terrific, Kevin. Thank you. You've all probably heard the term social determinants of health, and those are the conditions in the environments where people are born, live, learn, work, play, and age that affect a wide variety of in a range of health outcomes. Joe, can you provide some insight how you're addressing some of these social determinants of health and how they impact a person's overall health?
Yeah, great question, Neil. And I'll expand a little bit off of what Brad said and also what Kevin had mentioned. I think before we came on stage, you heard Brian talk a little bit about, 80% of all healthcare cost is really influenced by things that are outside the clinical setting, right? So you think about things that Brad mentioned, food insecurities. You look at transportation for supportive pregnancy care, right? You think about the housing and needs that Kevin had mentioned as well. So when you look at that, the only way you're going to make changes, right, first you have to measure that, right? And so I think in the industry today, there's a pretty common reference of American health rankings. They just came out, the latest American health rankings with women and children. And what's unfortunate for us in the state of Maryland is that we're still seeing a higher than expected premature infant deaths. And so you think about that, right? So that's a social determinant of health, transportation, whether it's getting, prenatal care or clinical care, right? Brad mentioned non-for-profit collaboration. So great example of this is focused on the March of Dimes, working with University of Maryland Medical System, working with MedStar, where we put together over the last couple of years a mama and baby bus that's a mobile unit, goes out to Prince George's County, goes to Montgomery County, and provides prenatal vitamins and also any type of attention and supportive care. And we're also doing something in Franklin Square with supportive pregnancy programs. So those are the things that we have to stay committed and be resilient in how we deliver that focus. And then when you look at food insecurities, the good news, when you look at probably 2012 and 2014 period compared to most recently 2019 to 2021, in this great state, we are seeing a decrease in food insecurity. And that's because of the collaboration with organizations like with Giant Food, with Capital Area Food Bank, and getting out not just food, but fresh produce that is going to drive a healthy living and healthy support system.
Would anyone else like to add to that answer?
The only thing I would say is, if you look at the data in Baltimore City and you look at what drives the costs within healthcare, there are 33,000 people within the city of Baltimore that drive 1.2 billion of the $2 billion spend. 33,000 people. If you look at the zip codes and their diagnoses, yes, they often have a chronic illness, but when you add mental health plus the chronic illness, you're talking about 3 to 5 times more. And if you add chronic illness plus mental health plus substance abuse, you're talking 5 to 7 times more. So what are the wraparound services that we collectively, and we came together as a hospital association in the city, and we took 200 homeless people and put them in homes. And we followed their trajectory of how they would use the healthcare system. We were able to decrease ER utilizations and hospitalizations to where it was statistically significant, to where we're continuing to fund that and looking at how to expand that, because the basic foundational elements of home and food in Maslow's hierarchy of needs becomes incredibly important for people to stay healthy.
That's tremendous. Thank you.
Neil, there's one other point I want to expand a little bit beyond the hospital systems, because health disparities is really much broader than that. And clearly the hospital system sees those who present to the hospitals, but the health disparities really reside in the community. You may remember that maybe 7 years ago, 8 years ago, there was a health department initiative by the governor's office to look at health disparities across the state and basically ask the question, how could we not only study what are the causes or what are the drivers, but what are some of the ways that we can make a difference? And with a combination of folks from Maryland, the University of Maryland, Hopkins, the health department, and so on, we really created a team. I was privileged to serve as the chair of that committee, and what I think was the most exciting is we found that communities that were low in basic health and social services had the highest morbidity and the mortality. And we introduced what we call the health enterprise zones, HEZs.
Right.
And the whole idea is that to the extent that we could replete those zones with deficiencies, where they happen to be in food deserts or tax credits or tax incentives, maybe loan forgiveness, you could begin to have a social impact. Not just a medical impact, but a social impact. So I think that one, we have a better understanding of what they are, what the issues are, and how we can potentially make an impact.
While you have the mic, can you talk a little bit about something Joe touched upon also, which is the status of infant mortality rates in Baltimore compared with the state and the nation?
Sure.
We're doing?
Infant mortality is a really important barometer of health care in any country. The World Health Organization uses that to assess the development status of any country in the world. In the United States, for example, there are about 5.4 deaths per 1,000 live births. And by the way, the United States is not very good. The lowest in the world is Scandinavia, Norway in particular, Japan, at about 1.5, 1.6 deaths per 1,000 live births. In Maryland, we're close to the national average. We're 5.7. Now, before I tell you Baltimore's, I need to give a little caveat. Baltimore has had an impressive reduction in their infant mortality rate through a number of initiatives. But we're standing at about 8.7 deaths per 1,000 live births. So you may say we're pretty high, but I'd say that is an impressive reduction. And the reduction has occurred because of some collaboration. Kevin mentioned collaboration being a buzzword, a collaboration between, we know that the medical school, University of Maryland, and the community created a collaborative where we went out and provide health education, teen pregnancy prevention program, nutrition program. One that I think is really most important that we should all remember, and that's how to put babies to sleep. It's counterintuitive to think the best way to put babies to sleep. Grandmothers, aunts believe you sort of cuddle them, you wrap them, and you put them on their belly. They seem so comfortable. It couldn't be the worst thing to do. They need to be sleeping on their backs. And the acronym that's used is back to sleep. And that in of itself has reduced the SIDS rates, sudden infant death syndrome rate, significantly. So Baltimore, with a number of initiatives, have actually reduced the incidence now to 8.7. I'm pleased with that number because it really shows that we can make a change. And if we can reduce it to 8.7, we can get it down to 6.7.
Right.
So I'm actually quite pleased, and I think it's a very, very important barometer of how health is occurring.
Very helpful, thank you. For any of the panelists, what do you consider the most exciting disruptors in access to healthcare? We've seen Dollar General running vans on the outside of their facilities. I can pick up my phone and for $29 get a telemedicine visit with Costco now as a Prime member. What do you think? What do you think?
I could
Great,
start.
Joe.
That's fine. I think back, and Kevin reminded me, when you think about the pandemic and the isolation and, a lot of the depression and the anxiety that was brought into our world that may have been there but not visible to that. The pandemic was tragic for many of us that lost loved ones and came across that chronic long-term COVID. But when you think about it, there were a few things that came out in a positive way, and one of those was truly, and you touched upon it, Neil, was virtual care. Virtual care, when we look at just kind of our data and we look at kind of what an annual amount of visits were for the Mid-Atlantic, which I'm responsible for within United Healthcare, we had roughly about 25,000 virtual visits annually. You look at our reports as of Q2 of 2023, we're on course to surpass about 500,000 virtual visits. But the key measure there is mental health. And so we have a huge increase in virtual visits being done through psychologists, psychiatrists, that in the past we didn't build that access. We didn't allow for that network. Now we do. And it also has removed the stigma of mental health, because if you think about that, right, and you're walking down the street, you have to go visit someone in person, you're looking at that, you don't want anyone to maybe possibly know, hey, I'm going to see a mental health specialist or a psychologist, when in fact, it's physical, mental, right, financial, that's a well-being. And so we've seen a tremendous increase in the virtual visits within mental health, and also children. The pandemic brought out a tremendous amount of depression in children staying home from schools as well, which now we're focused on.
Others?
I would say, Neil, I think we have to watch this. And the reason I say that, I have the feeling that this could create a greater divide from a health equity standpoint.
The haves and the have-nots.
Because when you start talking about $29 for a visit, for some of us, that doesn't seem like a lot. For others who are trying to put food on the table and pay their rent, $29 is a lot of money. And so my biggest concern as I watch the Amazons, the Dollar Generals, the venture capital companies, Costco, is they can pass the increased cost for them for your membership dues. I mean, there's a lot of ways that they can collect the cost structure that they're creating. We have no mechanism to do that unless Joe's going to promise to pay me more today. But my point is if we create those $29, our cost structure is much more than that. And so how do we do that and compete? And my concern is it's going to create a greater divide in who has access and who doesn't have access in this country.
Very valid point. And Brad, you wanted to say something?
Yeah, I agree with Kevin. I think we also have to look at some of these new, folks that have entered into the marketplace. We have to put it in its proper context because they're looking at a different size and scale. They may be looking at taking off the low-hanging fruit by walking into the Minute Clinic at a Costco and can do a quick screen. That's the space they want to play in. And we'll come to some agreement on how that works. But at the end of the day, I think you have heard from all of us, there's still the need for the academic teaching facility and the community hospital that are wearing so many hats right now for the community that some of these new participants, they're just skimming the surface. They're really not creating a big of a significant impact in terms of the needs.
Yeah. That's helpful. Katie, we're suffering a mental health crisis in this country, and certainly we're feeling it in the state of Maryland. Any thoughts on that and how we may address it?
Yeah, absolutely. We have during the total cost of care model, during our model, we have put a focus on behavioral health and mental health. We started in overdose space, but it's a really important aspect that of health that contributes to overcrowding in the emergency department, to clogs in the delivery system. I was really proud to put together through the all-payer rate setting system statewide investments to crisis services. And so we've, through a collaborative model with hospitals collaborating with community partners, are able to reinvest hospital dollars back into the community for crisis services. And it's really, we can't overemphasize how important that aspect of care delivery is for the health of the population.
Thank you. Joe, how are you addressing it from an insurer standpoint?
Yeah, and I wanted to just maybe pivot back through my response because I hit some of this just in how we're focused virtual care and with our members and your patients, the ability to give them $0 copays for virtual visits in many of our projects exist today. But I think Katie hit on some really good pieces there. When you think about the total cost of care model focused on mainly kind of a balance of financial payment, right, for the uninsured to the commercial to the Medicaid, Medicare, focus very on outpatient and inpatient. Then you bring in more the primary care physician component, which again would encompass specialty as it relates to, again, psychiatry or psychologists or counselors, family counselors. We want to provide as much access as possible. So, our willingness, I know Kevin was joking, but I'm sure I'll get a call later about, how do we make sure, right, that it's a fair reimbursement? Because even though it's virtual, that level of engagement, right, that access, we may be preventing an episode because now we've given them access to care. So I think we are very supportive, and I think really we have to continue, to Brad's point, to focus on the model that we have today and make it better. Bringing in new entrants from the market that don't have the level of experience that those on this stage do is not a very positive situation.
And one quick thing to add there is also the level of trust. Hospitals have worked with their community members and community organizations to develop trust with their communities. And for new entrants coming in, sometimes there's not that level of trust that is really vital to making sure you're connecting and resonating with patients that you serve.
That's a very valid point. Thank you all. Before I ask the last question, if you have a question for our panel, please form a line behind the volunteers should be in the, here we are. I think there's a question back here on the right, couple. Yes, sir, Dean.
Hello, Neil.
How are you? Good.
Anyhow, Boris Lushniak, Dean of the School of Public Health, University of Maryland, College Park. As I said before, go Terps and fear the turtle. That being said, we talk a lot about healthcare, and I know we sort of touched a little bit about this, but I, as a physician, both a clinician at times, but also dedicated to preventive medicine. What's the role of prevention in all this? Yeah. We talk about health care, but oftentimes, if you look at it very purely, and some will comment, right, that it really is not health care, it's sick care that we're providing, right? We wait till that end point, and we do marvelously as a nation, right? If I want to get sick anywhere on this planet, I want to get sick here. As long as I have access, as long as I'm in not a rural area or in a poor area, and as long as I'm covered by some insurance. But on the front end, what's the role of prevention in all this?
Thoughts? You want to take it, Katie?
I mean, it's a spot-on question, and in Maryland, we have been trying to move the incentives and investments more upstream so that we can meet patients where they are. We're trying to develop a robust primary care strategy to reach patients to that point to help both maintain health and address chronic conditions. And the community physicians and physicians are so important to that role to get to patients before an acute episode happens.
Dr. Reece and Kevin?
I think this is, Dr. Lushniak, thanks for the question. I think prevention is undervalued and underappreciated and becomes so very important in reducing health, in preventing disease, and actually decreasing morbidity and mortality. One of the things to clarify, however, having said that, all that is idealistic. That needs to happen, but doesn't happen, and doesn't happen to the extent that it should. Now, I want to take off what Katie said earlier. The rate commission system is an excellent system. We're the only one in the United States. We have a Medicare waiver, the only state in the union currently with a Medicare waiver. That really works very well as a wonderful safety net, a wonderful coverage for all hospital cares, regardless of someone's insurance status or the lack thereof. That doesn't work for the physicians. Physicians are reimbursed according to what I'd call the old system. Okay. If you have no insurance, the physician does not get pay. If you have Medicaid, Medicare, private, it is going to be stratified accordingly. So prevention is usually not a part of the insurance package, usually. Sometimes it is, depending upon the type. So that's why prevention is important and encouraged and supported. And I can't imagine any physician or any hospital administrator not finding that to be a very, very important part. However, reimbursement and the stratification from the physician standpoint is a factor that plays a role.
And then Kevin, then Joe.
Yep.
Yeah, I would say we also can't underestimate the importance of genetic findings that we know today. And if someone is predisposed for a disease, as a nurse, how do we begin to work with those folks early on so that we can manage that disease proactively that they might be at risk for? We've heard a lot today about the zip codes that you grow up in. how do we change those dynamics in those zip codes? Because we know that's an element that has to be addressed in terms of housing, transportation, access to food. And then the last thing is, I did not create the economic model for healthcare, but I would tag on to what Ben says. Until we change the economic model at some point in time for generations to come, in today's folks who are currently enrolled in Medicare, it will always be a sick model. But at what point in time do we begin to flip the economic model for the next generation that becomes more of an economic model that supports our providers doing the right thing around preventive medicine?
Yeah.
Thank you.
So I know you want to ask one question. I'll be 30 seconds
Okay.
now, I promise. But I think, we need to do more in this state. I have the opportunity that I support Virginia as well. And I will tell you, Virginia does not have a model like this. And so certainly support the model that we have here. But in our world, in the insurance side, we are very focused on preventative care through incentives with primary care physicians. And so, but we need to do better at not just the wellness exams, the identification of lab, biometric screenings, those things. There's a little bit of a disincentive, I feel, that's kind of an overshadow that happens in the state. So when I look at all of our medical spend in this state related to United Healthcare, we probably have about 16% of our Medicare under some type of incentive-based program. In Virginia, it's 70%. So that's something we have to look at.
No, I agree. It's changing the incentives again. We have time for one final question. I think there's a question over here on the right.
Hi, panel. I'm Ariel Long, and I'm running Baltimore's Top Tech Company of the Year. I, while working at MedStar Health, started what is now a $10 million company increasing feminine care access. And one of the things that has been shocking to me with regard to social determinants of health is the fact that these disparities cross all socioeconomic lines. I am a mom who is highly educated, who wanted to be the next Ben Carson, and still, in 2018, I found myself on life support for a month, and I lost a daughter to stillbirth. One of the things that we are finding on our side in the innovation economy is a lack of effort on dismantling some of the systems that make healthcare innovation low and slow. And so my question for you is, how are you using your impact in organizations to engage private organizations who can come in and support some of the outcomes you say that you're passionate about?
Yep, I'll take a stab. From the MedStar perspective, we created an innovation institute that you are aware of, and we're really embracing outside innovation and technology. But we need to understand it. I think you used the word, slow, and healthcare traditionally has been slow in terms of how we've moved forward, because we tend to hide a little bit at times, rightfully so, around the patient and what's appropriate for the patient, and the sense of control. Control for our clinicians to be able to make the appropriate decisions. But we need to embrace technology moving forward. We need to embrace innovation. We need to embrace AI, but we have to understand it. And we need to make sure that it aligns with the goals and values of our organization. And how do you strike that balance in terms of clinical care, clinical decision making, and how technology and AI and other areas can work collaboratively? But there are suitors out there, and you have to be willing to come to the table to have those conversations.
I also want to thank you for recognizing a great divide that's occurring, and I mentioned it a few minutes ago about the venture capital companies. We talk about vulnerable populations and access, but if you go to Northern Virginia, Montgomery County right now, which is part of the wealthiest part of this country, people don't have access to primary care. And the reason they don't have access to primary care is most of the primary care physicians have gone to concierge medicine. And so there's a huge elderly population that no longer has access to primary care, which from a prevention standpoint and managing their illnesses, primary care plays an incredible role. So there's a great divide that's occurring because of that. But secondly, the question is how do we collectively partner with what the community needs? Because what we may need in Montgomery County may be different than what we need in Baltimore City. So we've got to also be mindful that one partnership does not solve for the entire state or the entire region. We really have to be thoughtful of what's needed at ground zero in that particular community and partner with that community in understanding it.
And I'm going to change my hat for a moment and answer in the part of LifeBridge Health. We've got both a bioincubator and a tech incubator. Our tech incubator is in partnership with Care First. You just heard the CEO speak before this panel. We try to work with organizations from across the country who have modalities which can help both the payer as well as the provider in both reducing costs, increasing access, and we're finding that maybe 40–50% of those are beginning to take traction. So we feel there are opportunities to do more of that. It's expensive, it's time consuming, but it's something that clearly has a positive impact for the community. And I'm getting the signal to wrap up. So I think at this point, I'd like to thank our panelists. I'd like to thank all of you for your questions and appreciate the time.